Good morning, everybody. Today I'm going to give you a brief situational analysis on the management of postoperative nausea and vomiting. Postoperative nausea and vomiting is a multidimensional phenomenon that affects all stakeholders within the healthcare community. It is a complex issue which can have devastating ramification on an individual's health, along with impacting the multidisciplinary team's productivity and placing a burden on the hospital's resources and finances. Postoperative nausea and vomiting was first identified in the United Kingdom in 1848 after the introduction of surgical anaesthesia. 169 years later, we have improved the severity of the symptoms, however have found no universal cure. It is estimated that 20 to 30% of patients and up to 80% of patients in high-risk categories will experience postoperative nausea and vomiting. So we ask ourselves, why is postoperative nausea and vomiting a concern for our patients, our hospitals, and for ourselves? Postoperative nausea and vomiting is a serious and often overlooked complication which leads to one of the highest levels of patient dissatisfaction in the level of comfort, care, and overall experience throughout the surgery, which reflects poorly upon the staff and the hospital. Complications can be minor to severe, including electrolyte imbalance and dehydration, pulmonary aspiration, esophageal rupture, suture dehiscence, and bleeding. These complications can result in increased medical expenses, delayed discharge, readmission, and in some circumstances, the patient may need to be re-anaesthetised to fix and prevent any further damage. As health professionals, it is our goal to minimise harm that is done to our patients in order to optimise their health. Numerous researchers have studied the trends of postoperative nausea and vomiting and have identified three groups: patient risk factors, analgesia risk factors, and surgical risk factors. Patient risk factors are unique to the individual. A systematic review conducted by Alf et al. Found that the strongest predominant risk factor was if you were born to the female gender. Other predominant risk factors were a history of postoperative nausea and vomiting or motion sickness, a non-smoking status, age, and BMI. Analgesia risk factors are pharmacological interventions of which we put our patients at risk, either during the procedure or in the postoperative period. A systematic review conducted by Alf et al. Found that the highest predictor of postoperative nausea and vomiting was the duration of the operation, which often correlates with an increased dose of anaesthetic, followed by the use of volatile anaesthesia, postoperative opioids, and nitrous oxide. And finally, Alf concluded that surgical-related risk factors of cholecystectomy had the strongest predictor of postoperative nausea and vomiting, followed by laparoscopic and gynecological procedures. It is our role as nurses to identify these risk factors in the preoperative phase in order to predict and prevent nausea and vomiting in the postoperative phase. This should be a part of the preoperative checklist prior to surgery. To make it simple, two scoring tools called the Alf or Covanta tool have been developed and globally recognized to identify the risk factors leading to nausea and vomiting. These scoring systems work as a tick box approach. If a patient presents with no risk factors, they receive a baseline predictor score of 10%. For each added risk factor, adds an extra 20% to the predicted postoperative nausea and vomiting risk score. Cow et al. Expresses that a gold standard prophylactic antiemetic regimen has yet to be discovered, and therefore implementing the regimen can be difficult. There are several prophylactic classes of drugs that can be used for postoperative nausea and vomiting. Cow highlights the importance of using a multimodal antiemetic model for prophylactic treatment. This aims at using two or more interventions from different classes of drugs to act on the different neuroreceptor sites at high-risk patients. This has been seen to have the ability to reduce postoperative nausea and vomiting to less than 10%. Antiemetic drug classes that you will come across include the drug class serotonin antagonists, such as ondansetron, are a first-line regimen for prophylaxis, given 4 to 8 mg IV at the end of surgery. Glucocorticoid steroids such as dexamethasone, 4 to 10 mg IV, is dispensed after the induction of anesthesia. Neurokinin antagonists such as apropent is given orally 1 to 2 hours prior to the induction of anesthesia. Butyraphamone such as doprolol is given 0.625 to 1.25 IV after the induction of anesthesia. Doprolol is currently the most cost-effective antiemetic drug available. Dopamine antagonists such as metoclopramide is administered 10 to 25 mg IV 15 to 30 minutes prior to the end of surgery. And anticholinergics such as scleroplamide is a transdermal patch which is placed on the patient in the preoperative period or in the evening prior to surgery. Another approach is to address postoperative nausea and vomiting is the outdated views on fasting. Previously, it had been recommended to fast patients for extended periods of time to reduce the risk of pulmonary aspiration. However, fasting for long periods of time leads to the start of an uncomfortable journey for our patients. Patients can experience high levels of dehydration, hunger, headaches, nausea and vomiting, changes to one's metabolic state, causing future problems with insulin resistance, and preoperative stress response, which later on causes postoperative nausea and vomiting. Recent research suggests that we have the ability to help manage some of these symptoms by giving our patients a rich carbohydrate supplement drink 2 to 4 hours prior to surgery. In doing so, optimizing the health status of our patients without any associated additional complications or altering gastric pH content. Carbohydrate-rich drinks are beneficial for patients' mental and physical well-being. It contains maltodextrin, which produces an insulin response, boosting plasma glucose levels and preventing hypoglycemia. Due to its osmolarity of the solution, it produces a gastric emptying response, emptying the contents of the stomach within 90 minutes. This further reduces the risk of aspiration. A randomized control trial compared fasting to a consumption of clear fluids and a comparison to carbohydrate supplements 2 hours prior to surgery. The results they found were a significant decrease in nausea, with a p-value of 0.006 and a decrease in the number of incidents of vomiting in the 0 to 4 hours with a p-value of 0.004 and 4 to 12 hours with a p-value of 0.005. Next week, there'll be the second half to this in-service. We will have a special guest speaker, Dr. Tamsin Baker from Ensure, to give us further details on the preoperative carbohydrate supplementation, to provide us with some samples to try ourselves, to tackle this outdated issue of preoperative fasting. It has been identified that the translation of information into work practices may not be optimal, so I will be leaving a small questionnaire at the nurse's station with some free space if you would like to ask myself or Dr. Tamsin Baker anything in regards to the management of postoperative nausea and vomiting. I will happily discuss all of these questions next week. Thank you.